Welcome to AAPT Virtual Convention 2015. My name is Judy Neville, and I will be presenting the continuing education topic of the pharmacy audit. What is it, and are you prepared? I am a pharmacy auditor at HMS Federal, and I also work with outreach and education opportunities. So while this presentation today focuses on Medicaid auditing, the information is relatable to all types of third-party payers. And so my intent is to provide education on areas that we have identified as high risk or risk for pharmacy where audit is concerned. So provide education and support to help with cost containment solutions for your pharmacy. The objectives for the presentation: to describe the process for audit selection and review, to define fraud, waste, and abuse, and list examples of Medicaid program noncompliance. And again, those Medicaid program noncompliance examples are something that is relatable to all types of third-party payer program. Recognize the importance of documentation and following provider guidelines set forth by the payer. Describe how to report suspected fraud. And then the last part of the presentation, I just want to take some time to outline pharmacy technician career path as an auditor. It's a little bit more of a non-traditional career path, so I just wanted to share with you some of the perks of being an auditor and some of the qualities that you may possess that would make you a good pharmacy auditor. So the path that we're going to follow with the presentation today is first to take a look at the different mandates or laws that govern auditing within the pharmacy, to take a look at audit selection. Why is your pharmacy selected for audit? Comment audit findings, what to expect when that auditing process hits your pharmacy, and tips on how to work with the auditor or auditors in some cases. Proactive steps to decrease findings, so things that you can do in your pharmacy now, ideas to take away from the CE to bring to your pharmacy to help decrease findings. How to report fraud, and then again to look at that non-traditional career path as an auditor. So to begin with, looking at audit mandates, so when we talk about pharmacy audit, we really need to look at the mandates that authorize the payers to perform pharmacy audit. So the payers, third-party payers, the insurance companies, which would be the private insurance companies, Blue Cross Blue Shield, the public or entitlement, such as Medicare, Medicaid. So that's what we're talking about with the mandates. So on a federal level, Social Security Act, Deficit Reduction Act, and the False Claim Act all refer to pharmacy audit. Just a tiny bit of history. The original Social Security Act of 1935 was amended in 1965 to bring about the Title 19 Amendment. And that Title 19 Amendment is when Medicaid, the Medicaid program was first created. And we're all familiar with the Medicaid, which among other things provides medical services to families with low income. And then there's a section of that Social Security Act that established what's called the Medicaid Integrity Program. And what the Medicaid Integrity Program does is it looks for potential fraud, waste, and abuse, determines the fraud, waste, and abuse, and that's to help with funding for the program to kind of secure that funding. And so moving on, the Deficit Reduction Act is actually part of that Social Security Act. In 2005, the Deficit Reduction Act made a number of changes to the Social Security Act, and the changes were intended to strengthen the state's Medicaid program's ability to fight fraud, waste, and abuse. So in order to strengthen, there was more funding brought to the fraud, waste, and abuse arena. The Deficit Reduction Act also requires pharmacies that receive at least $5 million annually have to provide False Claims Act training. and those pharmacies also need to have written policies for detecting and preventing fraud, waste, and abuse. So Deficit Reduction Act, if, again, the pharmacy receives at least $5 million in payment from Medicaid program per year, there's some stipulations that certain training has to be provided to the pharmacy staff. And then to take a look at the False Claims Act, that relates to penalties involved in knowingly submitting a fraudulent claim for payment by the government. So that would be payment by Medicare and Medicaid. And the Act also outlines what's called whistleblower protection, and that's something that gives protection to the individual blowing the whistle on suspected fraud with that government program. So kind of the whistleblower comes from in sporting events when the referee would blow a whistle or blows a whistle because there's something going on in the game that needs to be stopped, that isn't right. You know, maybe there's a foul. So that's where the whistleblower terminology comes from. And False Claims Act has part of that written into it to protect that person who is reporting the suspected fraud, waste, or abuse. So again, the False Claim Act has some language in it that talks about a person who knowingly conspires to defraud the government. And the key word is knowingly, but there's also some terminology in there that talks about the pharmacy staff's responsibility to know their job, to be deliberate and knowing their job. So the other mandates that kind of allow for an audit to happen in the pharmacy, each state will have a law, pharmacy law written that allows the audit. There's also third-party policy and procedures and Medicaid regulation that allows the audit. So what I have on the next slide, third-party policy procedure, there's just an example in the italicized print of what would be written, an example of what would be written into the procedures that allows for an audit. So each third-party payer has a policy and procedure manual listing contractual guidelines for providers to obtain reimbursement. So this says whatever the name of the payer has the right to inspect, review, audit, and obtain copies of the pharmacy's prescription files, signature logs, and records. Claims submitted by the pharmacy and adjudicated by the pharmacy are subject to desktop and/or on-site audit. Incorrectly submitted and adjudicated pharmacy claims may result in an adjustment. The payer will recover overpayments identified through the audit. The pharmacy's refusal or denial to submit to and/or comply with the audit process will result in total chargeback of paid claims. Failure to comply with the audit process may also result in suspension of payment and/or possible termination from the network. So kind of to put this in maybe more general terms, basically what this is saying is that when the pharmacy signs a contract with a third-party payer to receive reimbursement, so again, most pharmacies have a long list of third-party payers who reimburse the pharmacy. So these are all of the patients, different insurance companies, Medicaid, different types of Medicare Part D, many different types of other third-party payer. Again, you know, Aetna, Blue Cross, Blue Shield are some of the larger payers. So when the pharmacy signs a contract that they will dispense the medication and then receive reimbursement from this third-party payer, they're saying that, okay, I allow the third-party payer to come in and audit, to take a look at the records and make sure that we're doing what we're supposed to do. And in the event that we are not doing what we're supposed to do on the pharmacy level, the third-party payer has the right to recover overpayment. So whatever was paid to the pharmacy that should not have been paid can be recovered, and that means that the pharmacy has to pay it back. So the last part of this says that the pharmacy's refusal or denial to submit or comply with the audit will result in total chargeback. And what that means is that if the pharmacy, for whatever reason it may be, decides to not cooperate with the auditing, then they will owe everything back, because the auditor is not able to look at records to find out, what errors there may be, if there are any errors. So it's in the pharmacy's best interest to cooperate with the auditing and to supply those records. So the next couple of slides, I just have examples of state Medicaid program regulations. Each state will have a different regulation, although it will be very similar. And I know we have participants from around the country, many different states. So again, I just pulled these two states out to give information, but your specific state will be very close to the terminology we have here. So Medicaid is managed on a state level. And the Iowa provision says authorized representatives of the department shall have the right to review clinical and fiscal records using generally accepted auditing procedures to determine whether the department has accurately paid the claims, the services were actually furnished to Medicaid members, and the claims submitted were paid during that auditing period. The next slide that I have refers to Nebraska, and again, it's going to be worded very similar. All services for which claims for payment are submitted to the department are subject to audit. During the review audit, the provider shall furnish the department or authorized representative the pertinent information, and so on. Okay, and so with these 2 pages that are outlining the specific policy for Iowa and Nebraska, kind of the reason I brought this to light again is to show that there are different regulations on a federal level, on a state level, and within that third-party payer policy and procedure that mandate that audit. And the auditing is important because in Medicaid alone, over $430 billion in Medicaid claims are paid annually. $430 billion. So there's a need to take a look at the record keeping with that and make sure that kind of everyone's on the same page with the payments and with the reimbursement. The auditing workflow, we're going to go through these steps, but to kind of outline it for you, and again, we'll be reviewing these steps. First of all, the third-party payer selects a pharmacy for audit. So we'll go over why a pharmacy is selected, why me? Why am I selected for pharmacy or for audit? Why is it my pharmacy? And keep in mind that since the pharmacy has contracted with a number of different payers, the pharmacy has potential for a lot of different audits from the different payers. So just because you have one audit certainly doesn't mean that you won't have another. You could have it be audited by your state Medicaid program, and then you could be audited by the third-party Blue Cross Blue Shield payer. And I know I keep using Blue Cross Blue Shield as an example. It's just one that kind of is on the tip of my tongue because it's so well known. But pharmacy, again, has a potential for many different types, many different audits from their different payers. So steps is first of all, that payer selects the pharmacy for audit. And then algorithm is used to get a random sampling from a claim universe, and I'll talk more about that to kind of explain those words that I'm using there. And then after the claims are selected for audit, the pharmacy sends the requested records to the auditor. So there's a couple of different types of audits. There's what we call a field audit and a desk audit. And so regardless of which audit, the pharmacy will provide the records to the auditor so that the auditor has them to look at. And which brings us to the next step, where the records are reviewed by the auditor. And when they're reviewed, the records are reviewed kind of in a standalone sense, and then they're compared against the data that we have gathered from the third-party payer. So does it match? So for instance, the third-party payer says that on claim 13, the drug Ducosate was billed and paid for, and does that match the data or the records that we get from the pharmacy? The next step then, when we're doing the audit, is to actually report anything that's non-compliant. So non-compliant means that there's some type of error. There's something that is an error, there's something that doesn't follow the policy and procedure laid out in the Medicaid manual, something that doesn't follow state laws, and so those are what are called findings. And then we report those findings to the pharmacy, and the pharmacy then has an opportunity to kind of reply to that, and that's what we call rebuttal. So the pharmacy can say, oh, you know what, I left out this record, I do have that information and here it is, that's part of the rebuttal. Or the pharmacy may say, well, I had prior authorization to bill for that, here's my prior authorization documentation. So once the findings are there, the pharmacy does have the opportunity again for rebuttal. And then if kind of the findings that the auditor have stand, then the pharmacy is able to go through a formal appeals procedure, and that's something that is handled on a court level. So there's an appeals process, and then the process of recoupment. And so then recoupment is where the pharmacy begins to make payment on what was overpaid in the audit findings. So audit selection. The pharmacies selected for audit are selected on a random basis, but that random basis is data-driven and from data of probable improper payments. So this slide talks about the Medicaid audit, where that involves CMS, or Centers for Medicare and Medicaid Services, and both the states working together to identify issues and providers for audit. So a number of ways, again, data analysis. A pharmacy may be selected for an audit because a patient reported or referred the pharmacy for audit. Maybe there's pharmacy staff who reported or referred that pharmacy for staff also. Just a few reasons of why the pharmacy is selected. On to the next slide, where it talks about audit triggers. Again, these are reasons why the pharmacy may be selected for audit. Data analysis or data analytics is useful information where we look at data, CMS looks at data, the state looks at data, and they kind of look for any outliers. They kind of look for any data that's maybe diverse, and that may be an audit trigger. So examples of the issues might be inappropriate use of codes on payment submission. So whenever adjudication takes place, the information that's adjudicated is kept on file in a database by CMS. And so if there are certain codes that are maybe overused or maybe inappropriate, that could be a trigger. A high claim volume, so the pharmacy may not be doing anything wrong at all, but there's a noted high claim volume. It's maybe an outlier. They have this particular pharmacy has a greater claim volume than other pharmacies. They may be, in 2014, their claim volume for the year was 570,000 claims, and then in 2015 it was 1,500,000 claims. So when there's that change in claims, that's also a trigger, or claim volume. High paid amount. So the pharmacy may be selected for audit if, for instance, they're in the top 10 of paid out amounts for the year. maybe a high refill rate, and that's again something that is data driven from the information that comes in during adjudication. High ingredient costs, that's listed. I already talked about different outliers, and I also talked about a noted change in the paid amount, not only the paid amount, but even the amount of claims that are processed from the previous year. So now we're going to look at next steps after the pharmacy has been selected. So for whatever reason it may be, your pharmacy, for example, has been selected for audit. So what's the next step after that? So an audit period is selected, and typically it's a 2-year audit period. So if you can think about how many claims were processed in that 2-year period, there's really just too many claims to audit each and every one of those claims. So let's say, for instance, it would be my team doing an audit, and we're with Medicaid, and so we're going to take a look at just the Medicaid claims. We're not going to take a look at Medicare Part D. We're not looking at Express Scripts or any other type of claims. We're just looking at Medicaid. But with that being said, that's a large amount of claims. So the next step after the pharmacy is selected is to compile a group of claims to be audited. So what we do is we take the universe of claims. So the universe would be all of the Medicaid claims that were paid in the 2-year time frame. And so let's just say that that is 200,000 claims. So our universe is 200,000 claims, and then we use an algorithm and stratified random sampling to narrow that 200,000 claims down to a more manageable amount, which is usually 200 or 250 claims that we actually look at. And then once we do the auditing and we have results, then those results are projected by extrapolation. And I want to just take a minute to go through some of those terms, because I imagine they're new terms, and don't want to get too in-depth with them, but just kind of want to give you a high-level overview of what the terms mean. So first of all, an algorithm is really just a formula that is scaled against that data to detect possible abnormal transactions or abnormal payments. And that can be overpayment, and that can also be underpayment. Sometimes there may be a focused algorithm applied to that universe. So an example of a focused algorithm is we're going to take a look at all adjudication codes of refill too soon. And so right away that's going to take that claim universe of 200,000, down to maybe 500 claims for the 2-year period. So that's a little bit about the algorithm. And the stratified random sampling then is just where there's a random selection of claims from that universe. It's really important that the claim is random. There's certain actual statistical programs that help pick random, and we want random samples because we really want the audit to be unbiased. And so it's important to know that when the auditing happens, it should be random and it should be unbiased as far as the claims that are chosen to audit. And then the last term I want to talk about, and this one really comes about later in the auditing process, and it's the extrapolation. So the findings or payment errors are disallowed, and therefore they're recoupable. And so what that means is that when there is an audit, and let's say, for example, there were 3 claims that had some type of error and they shouldn't have been paid. And we'll go over some examples of what those errors may be. But let's just say these 3 claims had an error and Medicaid paid the pharmacy a total of $30 for all 3 claims. Well, since there was an error and the claim should not have been paid, then Medicaid is able to recoup that. So with the extrapolation, That means that those results are taken from that small amount of 200 claims, and they're extrapolated over the universe of 200,000 claims. So kind of taking us back to the audit selection and the audit period, remember we're auditing for a period of 2 years with an example, let's just say, of 200,000 paid Medicaid claims. We can't audit all 200,000 claims, so we break that down into a more manageable 200 claims. And so whatever results we find in those 200 claims, we extrapolate back over that entire universe. Because if we found these 5 errors in 200 claims, we can say that those errors are occurring in those other claims that we're not able to look at. So that's what the extrapolation means. And just kind of a side note with the extrapolation is that the auditing that I do at HMS Federal does not pay per finding. So I think that that's important to know, and sometimes there may be there may be a misunderstanding that the auditor gets paid per error, and the entity that I am involved in with Medicaid audits, that does not hold true. Now, I can't say that doesn't hold true for all auditors, but it does in my case. Okay, so now we're moving on to the step of record review. We have found out which samples that we're going to audit, and the pharmacy has turned in their records, and so now the auditor does a review. And with the review, the auditor is verifying that there's efficient and appropriate use of the healthcare funds. And on this slide it lists public healthcare funds because, again, I'm being specific to Medicaid, but whatever third-party payer it is, they're going to make sure that it was efficient and appropriate. On the Medicaid level, the record review preserves the financial and operation integrity of the government programs. So $430 billion paid in Medicaid claims last year. So it's important to make sure that Medicaid programs remain viable for the population and patients who make use of the programs. And that can only be possible by kind of having checkpoints and making sure that there isn't fraud, waste, and abuse, and to try and deter that. And so we're also safeguarding and working on prevention to just ensure that the claim payment is accurate. So our overall goal when we audit is to just decrease that inappropriate payment. And we do an audit, and then we want to do some kind of education after that, so that the pharmacy provider can see, what we're looking at, what was possibly the error, and then, look at ways to remedy that, so that in the event of another audit, or not even in the event of an audit, but just to make sure that the payment is accurate. Okay, so now we're moving on to the record review and what the auditor actually looks at. So the auditor is looking at the records that the pharmacy turned in to make sure that the drug that was billed for was actually covered, that it's on the PDL or preferred drug list. So every third-party payer has a PDL or preferred drug list, and there's different criteria of when can a drug possibly be paid for that's not on that list. And so it's important to be familiar with that, and that's what we're going to look at. We will also look to make sure that the drugs billed for are approved by the Food and Drug Administration or the FDA. The auditor will look, I'm just going to skip the next point and go on to the last two. The auditor will look to make sure that the drug that's dispensed to the patient is what was billed for. So let's say, I don't know, that Lipitor was billed for, but atorvastatin was dispensed to the patient. Obviously, there's an issue with that, that's an error, and so that's an example of what we'll check. The same quantity patient received is what was billed for. So if the pharmacy billed Medicaid for 30 tablets, the patient should get 30 tablets and not just get 10. So then the point that I kind of skipped over in the federal and state rebate agreement is that most states, I believe there's only maybe 3 or 4 states that do not have a federal rebate agreement with drug manufacturers. So pharmacies must bill for drugs that are within that rebate agreement when they are billing Medicaid. And the drugs that are in the agreement are listed on the state Medicaid website or the federal Medicaid website. So it's important that your drugs that you bill for are not only covered as a preferred drug, they're not only FDA approved, but they also must be within that federal manufacturer rebate agreement. And again, these policies are all outlined in the third-party policy and procedure handbook, or sometimes it's called the provider manual or billing manual. So it's a good idea to take a look at that and understand. Some other things that we're looking for is to make sure that the NDC that was billed for matches up with the NDC on the label, the NDC that was dispensed, because there can really be safety issues in that too with dispensing a different NDC than what you have on record as dispensing in case of some type of a recall. And that's also important because Medicaid does DUR, or drug utilization review, according to the NDC that is billed for. So if the pharmacy bills for X NDC, but they actually dispense Y NDC, maybe there's some type of difference in dosing or in strength on those drugs that could affect the DUR that's done on a Medicaid level. Okay, other things that the auditor looks at is we want to make sure that the records that came to us actually have a valid prescription, that the refills were authorized, and that the pharmacy followed the threshold rule. And what I mean by that is typically the threshold rule is 75% usage. So what that means is that if a patient gets a 30-day supply, they're not able to refill on day 15. Typically that refill is going to happen on days 22 through day 30. So that's the threshold rule. If the pharmacy would refill on day 15, that would be what is termed a refill too soon in most instances, and would be subject to an overpayment. The refills authorized, and make sure those refills are authorized by someone who has the authority. So, for instance, when, let's say a patient comes in to have a med refill, they don't have any refills left, and so the technician calls the prescriber's office to get authorization for refills, or they fax the prescriber's office. So when that fax comes back to verify or to okay additional refills, we have to make sure that it's authorized by the right person in the medical office. So, for instance, can the receptionist authorize refills? No. It would have to say 3 refills authorized by Dr. Smith per Joni LPN. So that's what I mean by refills are authorized. Another example would be a refill request that goes to a nursing home when we're doing a fill for the nursing home or a cycle fill, and the patient needs more refills. So we fax or we call that nursing home, and we need to get refill authorization. So the med aid cannot authorize refills. We need to have an authorized person to give us those refills. The last point that I have on this slide is a pedigree in place. Effective June of this year, our pedigree laws nationwide started to take effect, and so the pedigree is part of the track and trace program with the drugs, and some states prior to this have had state laws mandating pedigree. So either for the state that would be audited, or in a few years when everybody's up to speed on track and trace and pedigree, that will be an auditing point, or is an auditing point, to make sure that, again, the pedigree is in place for the drug that's dispensed. Okay, so we're going to move on to being called for an audit and what to expect during that audit. So first of all, there'll be some type of initial contact from whoever is doing the auditing, whether it's a third-party payer or whether it's contractors through CMS. There'll be some type of initial contact, and that can be in the form of mail, hard copy mail. It can be an email. It can be both, and a phone call. At HMS Federal, we will always mail the information and then follow up with a phone call to make sure that the pharmacy received the information. There'll also be what we call an entrance conference, and that's after the pharmacy has received their initial contact letter or intake letter. We set up a telephone conference to make sure that, to answer any questions that they have, just to kind of outline expectations. There's also a document request where there will be a letter sent out and a list set out letting the pharmacy know specifically what is required of them to turn in for auditing purposes. There'll be an interview, verbal interview, possibly a questionnaire where the managing pharmacist, the manager who may not be a pharmacist, pharmacy technicians may be asked to fill out, and really these are going to be pretty straightforward questions about kind of the daily operations of the pharmacy. You can also expect different deadlines. The pharmacy has a certain amount of time to get records turned in to the auditors, so be cognizant of the deadlines. There should be a lot of shared communication. Part of the reason for my desire to present on the pharmacy audit topic is to help everyone understand that it's kind of a working together process. So there shouldn't be any kind of, hopefully shouldn't be any kind of fear involved with communicating with the auditor, asking questions. It doesn't just have to be at the entrance or the exit conference. Anytime the auditor will most likely give an email address, will give contact information. And again, another line with what to expect is there's different types of audits. There's that field audit or the desk audit. So the desk audit is where all the information, all the records will be sent to the auditor, and the field audit can still involve and will still involve sending records, but the auditor will actually come out on site to the pharmacy and spend some time in the pharmacy going over records and doing that interviewing and doing some audit tasks on site. And then the last I have with what to expect is that you will have some reports that come to you on different levels so that you can see the audit results or the outcomes. And then the pharmacy certainly has opportunities to respond to those reports and kind of supply more information that may help with any errors that were found during the audit and that were reported. Okay, so now we have tips with working with the auditor. Again, ask questions and communicate with your primary point of contact. So typically, there will be a primary point because the auditing entity wants to make this as kind of streamlined as possible for everyone involved. So ask questions, get the information that you need, gather the requested records, and include any and all kind of supporting documentation. And what I mean by that, some examples would be collaboration agreements between pharmacist and a prescriber. Supporting records would be like signature captures. And then adhere to timeframes and for document submission. So those would just be those deadlines. There may be times when the pharmacy needs to ask for an extension, and that's certainly not unheard of. I've had pharmacies ask for extension when they have had one of the staff out on maternity leave, and they were just short-staffed. Over the holidays, where they had different staff people taking time off, the pharmacies have asked for extensions, and that's certainly, that's certainly something that you can ask for, and hopefully the auditing company will agree to that, because again, it's a matter of working together to get the job done. Other tips, to ask a vendor for help with invoice records. So when you're audited, the auditor may ask for invoice records where they will take a look at your virtual inventory. And with that, it's going to probably help the pharmacy out a lot to just ask your vendor, ask McKesson or AmerisourceBergen or Cardinal for help with those invoice records, or maybe ANDA or whoever, whatever wholesaler or supplier you use. Get some help from them. The next point that I have on here is the on-site audit assistants, get them out the door. And what I mean by that is when you have that field audit and you have the auditor on-site, I'm sure that they want to get their job done as efficiently as you would like them to be done as quickly as possible so that you can kind of get on to your business as usual. So the best way to do that is just assist them in what they need and in the records that they're looking for. Another tip is to include key personnel in the audit meetings. So when the pharmacy is selected for audit, there may be a technician who's selected to compile all of the records that the auditor needs. So that's someone who would certainly want to be in the audit meeting. Maybe there should be 2 technicians. Maybe there'll be 2 people working on it, helping each other through it, or maybe there should be 2 technicians in case kind of the technician who'll do the work and maybe the alternate. Life happens, and what if the technician who's chosen to do the work, has some type of family emergency, becomes ill, then you've kind of got the backup person there to help out. Key personnel, some pharmacies will include an attorney in the audit meetings, and that's fine. In fact, that's something that happens pretty often. So maybe the pharmacy owner, the manager, key personnel. Another tip is to ask questions to fully understand what's in that audit report. And again, the audit report is something that comes after the auditing is done, and it'll be a report that will say the types of findings or errors that were noted in the claims. And, just ask questions. Read through it, take your time reading through it, ask questions. Some things that you might want clarification on are the acronyms that were used by the auditing team, and the error codes. So, for example, an error code that we use, the acronym is INP, and it stands for invalid prescription. So just make sure you understand what is in those reports. Another error code that we use is MRSS, which stands for Missing Record Specific Service. And so that's where, for whatever reason there may be, when we did the audit, there was a record missing. So for instance, maybe the signature capture was missing, and we need to see that record to make sure that the patient received the medication that Medicaid or the third-party payer was billed for. Supporting regulations, and that's, we talked about mandates and regulations at the beginning of this CE, and these supporting regulations, what I'm referring to here, are regulations that fit the finding. So for instance, if there's a finding or an error that says that, let's say for instance, the prescription was missing a signature, then there would need to be supporting state regulations or supporting regulations in the policy and procedure manual saying that a prescription does indeed need to be signed. So whatever error there is, there should be a correlation with the regulation that backs up that error. Next slide, number 24, is audit outcomes. So this is kind of what happens at the end of reporting. There is an overpayment that may be calculated. And again, there are cases where there can be underpayment. But the overpayment is the amount paid by Medicaid or the third-party payer to that provider that's in excess of the allowable amount. And the payer will be notified in writing about that in one of the reports. So again, any kind of questions you have about that, make sure you communicate those questions. So the pharmacy will be given a certain amount of time to repay that money that was overpaid. And just a couple of scenarios. If the provider is not able to repay that money, the Medicaid or whoever the third-party payer is may recoup that money by reducing future payments to the pharmacy. So for whatever reason, if the pharmacy doesn't pay back or isn't able to pay back, it may result in, okay, from now on when you dispense to one of our patients, we will, not repay you or reimburse you only a portion. Another thing that may happen is if the pharmacy does not pay back, the third-party payer may discontinue the contract with the pharmacy, so the pharmacy won't be able to get reimbursed for any of the patients under that third-party payer contract. So those are just some of the examples of what may happen with payment. And this is an example, recoupment example on slide 25 when we're dealing with Medicaid. So what happens with Medicaid overpayment is that the state collects the overpayment money from the pharmacy, and then the state also has to pay the federal government back, because with Medicaid is a federal program, but it's ran by the state. And so there's what's called a federal share that goes into that state program, and so therefore state has to pay back some of that money or the federal share to the federal government. Okay, so moving forward with proactive steps to help ensure kind of a smooth audit and to decrease those audit findings. First of all, keep accurate and truthful records. One thing prior to pharmacy audit, I was pharmacy educator, and one of the things I kind of tried to drill into my students was that if you did it, document it. If you didn't document it, you didn't do it. That documentation is so important in all aspects of pharmacy, from compounding sterile medication to third-party payers. So make sure you document. Document is so important, documentation. Keep your records, your systems, or keep your records organized. Sometimes I perform audits where the prescription is missing and the pharmacy can't come up with a prescription. So that's just one example of keeping things organized, keeping those prescriptions in the chronological order according to prescription number and getting them filed. And of course, always submit legitimate and accurate claims. Know the plan formularies, know what's on the preferred drug list, and kind of an important suggestion here is to investigate denials and overrides. So when adjudication is happening and a claim comes back as denied, instead of just overriding it automatically, kind of take a minute and consider what's going on with that claim. So possibly it's a refill too soon. And if you go ahead and override it, get some documentation as to why you're doing that. So then when and if an audit comes around, there's documentation to back up what you did. So first, an audit comes around 2 years from now, you're not going to remember why you overrode that adjudication error code. And secondly, you may not be at that pharmacy any longer. So documentation is very, very helpful and actually really necessary for the smooth operation of the pharmacy. Some more proactive steps. I have here vendor software updates, dispensing software alerts, standard operating procedure for telephone orders, in-house pickup and delivery signature logs, staff training, open communications, and knowledge of state, federal, and payer rules and regulations. So kind of in a nutshell with this, the vendor software updates are there to help have the vendor help you with updates is what I'm saying with this. So with your invoicing, one of the keys here is with that NDC billing. So let's say that you get in, pharmacy manager goes to a trade show and buys a bulk of medication at special trade fair pricing, and you need to get the NDCs into the system. See if your software vendor can somehow help make that process easier. Make it scannable instead of having to key in all of the different NDCs. If there's some way to make sure that your information in your database is accurate, have your vendor help you with that. The dispensing software updates, you know, if there's an audit at your pharmacy and you see a trend that refill too soons are being overridden, and that was something that, you know, was kind of a high alert and got you in trouble with the audit, and you're finding that that's something that really should not be done, have your vendor help you with an alert with that. So the vendor can adjust your software, and when that refill too soon comes up, software vendor, have them help you with it where maybe it isn't able to be overridden. Maybe it needs to be signed off by a second person in the pharmacy before it's overridden. Just suggestions may help with that. Standard operating procedure for telephone orders. Make sure that when that telephone order comes in, that first of all, if it's a new order, if the tech can take it, great. If the tech can't take it, make sure it's handed off. You know, put that order to writing, and then, you know, put telephone order on that actual order that you take in, something that's going to document that this is where the prescription originated. The in-house pickup and delivery signature logs, make sure that they're for the correct amount that was dispensed to the patient, that they're dated correctly, and that it's for the correct drug. Because this is something that the auditor looks at to make sure that the patient received the drug that was billed for. So something that you definitely want to have accuracy with. The training staff on all the different key points to make sure that the pharmacy is compliant, and just having that open communication so that if a staff member feels like there's some type of process that isn't being followed correctly, that they, you know, maybe don't have a fear in communicating that. Open communication really helps the pharmacy, you know, probably run a lot smoother. And just knowing those regulations, the last point, is going to be helpful again when going through payment, and why is this denied? Oh, it's denied because it's not on the preferred drug list, kind of thing. Okay, now we're going to move into fraud referral, and just a quick definition of what fraud, waste, and abuse is, and I'll try and give some examples as I go through this. So fraud is the biggie. Fraud is the intentional deception or misrepresentation made by a person who has knowledge that this deception could result in an unauthorized benefit. And so the key is that it's knowingly and willfully. Waste is overutilization or inappropriate utilization, and it's usually, it may not be intentional, it's usually not a crime. So an example of waste that I have is just where the pharmacy technician or pharmacist acts in gross negligence that causes some type of additional expense to the government, or to the third-party payer. So an example of that would be, that I have seen in pharmacy audits is what's called prescription splitting. And the prescription splitting is done to receive additional dispensing fee. So what I mean by that is that the quantity written is for number 30, but the pharmacy decides to, for whatever reason, dispense 10 at a time. So with each 10 that's dispensed, the pharmacy collects a dispensing fee, and that's waste, and that's a type of, can be a type of fraud. So if the pharmacy decides to split that quantity of 30 up, they have the liberty to do that, but they can't charge the dispensing fee for each time that it's dispensed. Only one dispensing fee is allowed. And then the last one, abuse, is provider practices that are not fiscally sound, reimbursement for services not medically necessary. So an example that I have for abuse is, and again, abuse can happen on different ends. It can happen on the prescriber's end, on the beneficiary or the patient's end of the spectrum. So my example here is, let's say the patient or beneficiary visits the dentist and has some dental work done, and the dentist says, okay, I'll prescribe you some hydrocodone for pain. And the patient says, well, I don't think I'll have any pain, I don't need any. And the dentist will prescribe number 30. So that's an abuse, because did the patient really need 30? Maybe the dentist could have prescribed number 5. And so then, taking that another step, so that would be abuse on the prescriber's part for prescribing too much of the drug. On the other end of the spectrum, it could be, the beneficiary goes in looking for the medication when they don't actually need it, stating that they're in pain when they don't actually need the medication. There's also that type of abuse. Okay, so the next slide on fraud referral. Sometimes an audit may begin with what's called a fraud probe. So that's where there's some strong analytics or strong evidence of suspected fraud in the pharmacy. And these are just some common types of fraud, waste, and abuse within the Medicaid program. Ghost patients, and that's where a pharmacy is going to bill for a service or a product that is not actually given out. So somehow the pharmacy will get information on a ghost or a pseudo patient and do billing, and there's actually no service exchanged. Medical identity theft, I think that's pretty self-explanatory. Billing for unnecessary services and items, and billing for something that's not covered. Upcoding is billing for a more costly service than what's provided. And so this is maybe going to come into play with some of the MTM practices, some of the kind of enhanced pharmacy services and provider status services that the pharmacist provides. Unbundling is charging for items separately rather than as part of a package, because when they're unbundled, the reimbursement rate for each service is higher than when they're packaged together. So example of this in the pharmacy might be let's say IV therapy is bundled together with the supplies that are needed to deliver that IV therapy. So let's say the IV therapy is bundled together, the medication is bundled together with the IV tubing. So the pharmacy would unbundle that and charge separately for the medication and separately for the tubing, which would result in higher costs. Kickbacks is, receiving remuneration from some group or some person for maybe dispensing a certain drug. And then beneficiary fraud is that which happens on the end of the patient, maybe some types of doctor shopping, and then I think most often we see the beneficiary fraud with the narcotics, sometimes with the C4 meds also. So pharmacy staff can report suspected fraud, waste, and abuse to state Medicaid, to the Office of Inspector General, and to the Medicaid Fraud Control Unit. And this would be done to really protect your pharmacy, protect your patients, and just preserve our Medicaid and our healthcare program. So the next slide that I have talks about how to report fraud. So the first is a national number that you can call. It's the Office of Inspector General. There's an 800 number listed there, and then there's also a website to go to. The next one is on a state level, and really when you're reporting the suspected fraud, you would want to do that on the state level with, if it's Medicaid, with state Medicaid. And since we have participants in the CE from all different states, or many different states, I couldn't list all those numbers, but there is a website here that you can go to, and it's on Centers of Medicaid and Medicare Services.gov or CMS.gov, and then there is a section on there denoted to the fraud, waste, and abuse. So just to kind of reiterate best practices for prevention, first of all, verification, and that goes along with making sure that pharmacy staff is verified on the exclusion list, and that's the exclusion list with the OIG. So any person who has been convicted or is not suspected, but is in the process of possibly being convicted for some type of fraud involving Medicare or Medicaid is not able to work in the pharmacy that or in any healthcare environment that accepts payments from the government. So that's what that exclusion status and exclusion list is about. Make sure that your staff is up to date on their licensure and registration. The vendors, which are the wholesalers or the suppliers, need to be licensed with the state. Take a look at your prescribers, that they match up both their NPI and DEA numbers, that they belong to them, that the names match up. We talked a little bit before about the drug pedigree, making sure that's in place. So verification on those points. Staff training, make sure the staff knows policy and procedures, that there's open communication and plenty of documentation. In the next column at the top, internal quality assurance, perform spot checks and initiate corrective action plan to correct oversights, and then determine if additional safeguards need to be put in place. An example of that would be like some type of software updates to help make sure that certain things aren't kind of on automatic override during adjudication. And then workflow, just take a look at the telephone orders, how that's taking place, how refills are being documented, making sure that the scripts are signed, that the refills are authorized by the right authorized person. The services and meds that are dispensed, that the patient signs the signature capture for those. Those are just some suggestions for best practices for prevention of overpayment. So this next slide talks about some provider tools, and if you're a technician who's in the place of educating or training at your pharmacy, maybe you're a lead technician, these are some great resources to share with your team. The first one is, again, on cms.gov. If you just log in, cms.gov, and there's some different program integrity education. And then I also gave the list to check on the exclusion database. Now, these links that I have in here, I have included in the packet handout for you, so that you will have these after the presentation to refer to if you choose to. Okay, and just quickly, because we are a little bit past our 1 hour, I just quickly want to wrap up with talking about a career path as a pharmacy auditor. The primary tasks of the pharmacy auditor focus on analyzing records to conduct post-payment audits. So here's some of the things we look for in the pharmacy auditor. Obviously, there needs to be competence in the pharmacy field, knowledge of what you're looking at. You want to be detail-oriented and I think that any good technician is very detail-oriented. You need to have objectivity, and that's important in looking at the records, and that includes being impartial, kind of being free of conflict of interest, and the independence means that it kind of goes along with conflict of interest, is that you need to make sure that when there's a pharmacy that comes up for audit, that you're kind of independent from them and there won't be any type of conflict of interest. And also effective communication, written communication as well as oral communication is, I think, probably important in any pharmacy setting. And then the perks for being a pharmacy auditor is that it's just really a unique kind of non-traditional career path for a pharmacy technician. You have kind of a behind-the-scenes view of compliance and non-compliance and why documentation is important. In many instances, you're able to work from home. At HMS Federal, we have a work-from-home environment, so there's many perks with that. Not driving in traffic, kind of being a little bit more, having a little bit more freedom with your work schedule, and that helps when there's young kids or school events to attend. And it's a really important job to safeguard taxpayer dollars, and that's in the case of the government programs. But even with third-party payers, it's an important job because you are really safeguarding the healthcare system. With pharmacy audit, there's the ability to travel because you will be doing field audits, so you'll be able to visit different areas of the country where maybe you wouldn't have had the opportunity otherwise. And then, there's also the thought that you're not going to be dispensing, and so there's less risk, definitely, of patient harm with some type of a med error. So again, my name is Judy Neville, and I have my office and cell phone number and email address here, and again, I'll include that on a handout in your packet. You're welcome to give me a call, contact me if you have interest in becoming an auditor. I can help you out in that way. And certainly if you have any questions or comments on my presentation, I welcome those. Thank you very much and have a good rest of your day.